In Tune. Conversations on audiology and balance. An Inventis podcast.
Good morning, everyone, and welcome back to this new episode of In Tune, the Inventis podcast dedicated to audiology and vestibology. Podcast created by Inventis for its 20th anniversary of activity in the country. Today we are moving to the field of audiology, specifically in hearing aids. It is my great pleasure to introduce our guest, Dr. Cristian Borghi, who is joining us today. Dr. Borghi will now share some insights and tell us a bit about his professional expertise and background. I'll give a brief summary. He is the branch manager for the Reggio Emilia offices. He works for Amplifon and is also a university lecturer in the hearing aid course at the University of Parma and Padua at the Venice campus. Then there are many other things that he will now tell us about. Welcome, Cristian, and thank you for giving us the opportunity to interview you.
Mario, thank you. It's truly a pleasure for me to be here today, also because it's a way for us to see each other since we talk regularly. We've had a friendship for so many years now that I've lost count. I am the self-manager for the two Amplifon branches in Reggio Emilia, and I've been working since 2005. So this year, it's been 20 years that I've been working. So I'm a friend and also a lecturer in Parma, where I graduated in the degree course in hearing aid technology. I've been doing that for about 15 years now, and for about 4 years since the audiometry program started in Venice. I'm also a lecturer in Padua, specifically at the Venice branch, for a hearing aid technology program, but under the audiometry degree course. They really wanted it because when they first contacted me, they couldn't understand the connection. And the coordinator, Professor Santarelli, said, "For me, it's essential that audiometrists know what you do. So I care about having a hearing aid technology program to be able to delve deeper into this method. I mean, this method, this collaboration, this expertise, which shouldn't just stop."
You've immediately touched on an important point, audiometry and hearing aid technology. How do you see the future of these two disciplines? Will they end up going hand in hand? Will there be an audiologist like there is in the rest of the world? Or will they continue to be two separate entities?
Well, consider that our profession became fundamental as a degree course starting in 2002. Before that, it was a university diploma. Even before the university diploma, there was a single course for hearing aid technology and audiometry. When I started with the diploma, and then it became a degree because I started in 2001, 90% of the classes were held together. And for the past 3 to 4 years at the ministerial level, they have been considering merging the two tracks. It is possible. Obviously, what might be necessary is to extend it by another year, mainly because of the internship component. Because in terms of theory, a lot of things are combined. So you just need to implement both sides. With 2 or 3 courses, but when it comes to internships, both the hearing aid internship and the audiometry one. If I think especially about the vestibular part, it's not an internship where you can just stop. Obviously, when it comes to tonal audiometry, speech audiometry, and so on. So there's the whole vestibular part, which is absolutely much more complex, all that concerns potentials. So in short, since these are 2 paths where the internship component is significant, and since these degree programs qualify you for the profession, we don't have a state exam in order to proceed in practice. But the graduation session itself is a qualifying exam. And then, well, you know this better than I do, since this year you're going through the same program, we'll have a practical part and a thesis defense part. So the practical part is what actually qualifies the student for our profession. And that's fair enough. I mean, that could be the future, also because the drop in enrollments after COVID has been really significant at the university level. For the first time, I saw some of my students in Venice who had already graduated in hearing aid technology and are now switching to audiometry. That never used to happen before. Before it was audiometry, and then they would move on to hearing aid technology. Now, on the contrary, many people are actually trying to get a double degree, which could be useful for them.
A much more comprehensive and detailed profile, also considering how our profession is changing, how our professional landscape is rapidly changing.
Quite a lot, absolutely a whole lot. Because if I really take a moment to think back to just a few years ago, it was really completely different. I said a lot just to be modest, but honestly, I'd say everything. So many things are changing, from the very concept of the audiologist's role to the division of products and skills. Rightly so, products are changing, and so many new products are coming out that aren't hearing aids, but that are actually connected devices. These are things that are actually part of our work and can help our patients. There are so many new approaches coming in, and what worries me a bit is the fitting process. where it seems like nowadays you can just wake up and invent your own method. The more of them there are, the more tools we have, the better it is.
Lately, there's been a proliferation of methods, protocols.
As long as we're talking about methods and protocols that are validated, I'm fine with it, because for something to be considered a method, it has to be scientifically validated. But when I pass off something as scientifically valid when it isn't or isn't yet, that's what worries me a bit.
It's more about how it's used, really.
It is a
Matter of terminology?
Of terminology, but one that makes a big difference scientifically. I mean, it's like saying whether it's valid or not. It's something I'm working on, and I can assure you that getting a publication, a scientific validation, is not easy. Among the various things I've done in recent years, I've been part of the working group for the new guidelines for hearing aid specialists, but also on the panel for cochlear implants for the new cochlear implant guidelines. And since the cochlear implant panel had to be scientifically validated by an external institute, I can assure you that we have made a huge number of modifications and scientific checks. Not us personally, I mean, but we regularly receive review emails at the scientific level in order to be published. So publishing something that needs to be recognized at the scientific level, which is not the usual publication of "I did this," is very complex. So the important thing is to be clear with colleagues about what it is. Then I repeat, the more arrows we have in our quiver, the better. What worries me a bit is that everything I'm seeing now is very external to the patient. I mean, in the sense that it relies a lot on measurements, on curves, but we are completely losing the centrality of validation by the patient.
Sorry to interrupt you, but maybe this way we can define things better. So, in your opinion, there is a path that is very sterile, that finds a procedure, in any case, a path to follow, but without truly taking into account the centrality of the patient.
Absolutely. If we talk about patient centrality, since we do tests on the patient, then all of them are supposedly patient-centered. But in none of these have I seen, what condition does the patient have? Because, it's one thing if it's a typical hearing loss, it's another if it's an auditory neuropathy. And how long has the patient been deprived? Because it's easy, let me give you an example, to fit a hearing aid for a patient who lost their hearing 3 months ago or 40 years ago. Are there any conditions associated with this? And what are their needs? I mean, I'm seeing more and more patients with mild hearing loss who have major issues because of their lifestyle. So then,
even from my own perspective, that kind of seems to completely undermine the whole idea of acoustic rehabilitation. Wouldn't you agree?
Absolutely. And acoustic rehabilitation isn't just about the curve, No, because nowadays there are people who say, I can use a basic product or a top-of-the-line one and make them work the same way. So we have a completely different logic when it comes to hearing aids. If you tell me you can achieve the same results because you can provide the same curve and you can actually get identical prosthetic performance, it's okay.
But it's not that obvious either.
It's not obvious, but let's assume it works for us. Same bandwidth, same electroacoustic characteristics. I managed to get the same result in terms of curve and performance. I have a cooperative patient because even there, they need to respond to me regularly. They can't lose focus because otherwise I will have different results because they are subjective. They are not measurable objectively, but that's okay. Okay, but what's the basis? That is, what is his pathology and what is his situation? I have mild hearing loss. I can bring it back to normal hearing. I can solve it for you. No, it causes you problems in noisy environments and I need special algorithms or external accessories because I have to be able to purify the signal for you. If you have neuropathy, it's the same as correcting you for me. The curve is almost useless. I have to purify your voice as much as possible and filter out the noise as much as possible. And so I got the curve right there for you and solved something? No, that is not quite right. Or perhaps it even got worse to a staggering 9 out of every 10 cases. Your issue then, that is, truly understanding what the patient's specific needs are, is absolutely fundamental and critical. And it almost seems like now there is a competitive race to successfully reach the target curve. I got there at the target curve, so that's fine.
But that could be an element that can give you important information to be able to proceed.
Exactly, thank you. If I then need external connectivity, if I need a specific algorithm, I do not have it. So how am I supposed to work?
You're preaching to the choir because over the years I've come to believe that best fitting doesn't exist. So those who say, I found the way to achieve the best, well, I don't believe it, and I say this with complete intellectual honesty. I think there's more of a best fitting area, and this area can be very broad. Because, as you say, in an environment, I need certain things, while in another environment, maybe I don't. So the question I want to ask you is, what are the regions, the boundaries of this best fitting area? How effective can a fitting be in a given environment? And then maybe if you change the environment, does everything change?
Well, it depends more on the patient's needs and their background than on the environment itself. Because why restore a threshold? Let me give you an example. For an elderly patient who might spend 90% of their time at home, there you might have one type of best fitting, while a patient who has difficulties in noisy environments, and even if, let's say, they have only mild hearing loss, they might have a crucial job where I need to be able to understand things in a certain way there. My best fitting is different. A patient with auditory neuropathy who has zero problems in quiet situations, but as soon as there's a little radio playing or any background noise, they get completely lost. That's a whole different case. Can we always solve everything just with hearing aids? No, that's not necessarily the case. I can assure you that over the years, I've had cases where, in order to try to solve the situation, I didn't have to adjust a single curve. Let me give you an example. A patient who had minimal hearing loss at a single frequency, but he was a Reiki massage therapist, and he told me, I have some soft music playing, and every 3 minutes there's a little bell because I need to change the
therapy I'm doing. And it was exactly the frequency that was impaired.
If I can't hear the bell, I can't work, and I can't just keep looking at the clock to tell me when. Of course. Here, did the curve need to be corrected? No, because it's just a slight drop at 3,000. He had some listening difficulties. No, 0. If he had done any other job,
he wouldn't have even noticed.
I once had a specific patient with auditory neuropathy who doesn't use hearing aids at all, but really, is that even possible? A very extreme case, where we ran tests to try out different hearing aid features and a bit of artificial intelligence or not, where I did this for her. In vivo measurements, not to correct her curve, but to give her 0 gain, to compensate for the occlusion of the cochlea. I wanted to be able to understand, to analyze only the algorithms, so I didn't want to correct her curve in that case, because I needed to understand if, by purifying the voice, I could work in a certain way. There, the in vivo measurements helped me achieve 0 gain, so much so that when I later tried to do standard in vivo measurements to also compensate for her hearing, the immediate impact was negative. In other words, she told me, yes, I hear louder, but it's more tiring for me. These were empirical tests that we did, but as I was saying before, let's try to have as many arrows in our quiver as possible. But how do we use them, and what should we use based on our skills? And then depending on who we have in front of us. In other words, there shouldn't be a race to reach the famous curve, because otherwise, so what's the risk? That you reach that curve. I found you a 0.5 improvement in the matrix, you have to adapt, and that's fine? No, because there may be other situations where I have other needs. Just think about someone who has poor discrimination, like in cases of neuropathies or severe hearing loss, or particular situations where the tonal doesn't match the vocal. Okay, I'll restore your threshold. I'll do everything possible and imaginable, and I managed to solve it for you. You could still have extreme difficulties with encoding. And so, for example, I might need an external microphone, or as we mentioned, new devices like smart glasses that can display subtitles for me.
Of course, yes, it's a kind of help that goes beyond just the device itself. You touched on a topic before we move on to pediatrics, because I'm really interested in discussing it with you, artificial intelligence. Today, it worries many people. For some, though, it seems to be an extremely important aid, and for some, it's even considered the future of hearing aids. Hearing aids, like many other jobs. What do you think?
And I'm extremely in favor. The important thing is not to believe everything he says. Let's start from this assumption.
The degree of hallucination is still very high, therefore it could give completely misleading answers.
Absolutely, yes. For many things, I even have fun using it. And I see that sometimes I end up arguing with it in a good way. Or I say, look, you told me it was like this, but it's not. No, guys, it's unbelievable. If I think about our industry and the products that are advertised as having artificial intelligence compared to what artificial intelligence can really do, to me, we're light years behind. I think we could really make much better use of it. I'll give you a simple example. Why don't we have voice commands? Why can't I put on my device and say to it, hey device, turn up the volume for me? Why do I still have to use an app or buttons? Because I can interact with Alexa, Siri, GPT, with anything using my voice, but I can't do it with the device.
But we'll probably get there, right?
Well, I hope so.
Soon?
And I hope it happens very quickly too.
Well, the competition between the brands is really fierce, and every year there's something new.
We need to speed things up. Another thing that I think is critical right now, if I think about the last 2 products launched commercially, is advertising artificial intelligence. They have 2 completely different approaches. And the message that's coming across, I've talked about this many times with colleagues at the company, makes you feel better in the midst of noise. Can you tell me how it works? Because it really does make you feel better in certain situations, but the 2 logics are diametrically opposed. Because one works in a 360-degree way, not by reducing the noise, but by emphasizing the speech. The other one, which is more An evolution of an extreme directional system, which isn't automatic but manual, focuses the voice for you, but drastically reduces the noise. So much so that, in the case earlier with the neuropathy, for which I wanted to run these tests, I actually compared these two situations, because I had some ideas and they were confirmed, but even there, both are valid, both are really excellent. But what do I need? I mean, do I have a patient in front of me who has more specific problems with noise, so I need to filter it out for them, like AirPods do, canceling out the noise for you, having some kind of ANC and working in a certain way? Or if noise isn't a problem for you, then it's enough just to help you hear voices better. So we're making progress, but what worries me is the lack of technical clarity in certain situations. Because nowadays, when a new product is introduced, of course my product is the coolest, the best and everything, it makes you hear better in noisy environments. But can you explain to me how it works? Because the audiologist needs to know this. And for me, those are two excellent products, but in some cases, one is useless and you need the other and vice versa. Conversely, both of them have this concept of artificial intelligence. Yes, thank you, but they work in completely different ways.
Do you personally feel and believe that various other consumer products, perhaps those outside the hearing aid sector, so more commercial ones, could begin to move in this specific direction much more quickly?
Just try to think simply the noise reduction they provide you. With the original first-generation AirPods Pro, we specifically conducted a comprehensive performance test 3 years ago regarding their noise cancellation capabilities. We are comparing these items with a top-of-the-line model from one of our suppliers. AirPods were seriously crushing them, heavily, still using an occluded dome to compare the occlusion of the AirPods.
This makes me strongly believe that there will be a pod in the future. There are many individuals living with significant hearing loss who will eventually turn to various alternative products that will not necessarily be traditional medical hearing aids. The market has been suggesting this to us for a few years.
Absolutely, yes, but in my opinion, there may be some products that can be used with hearing aids. Earlier, I mentioned glasses. If I think about the latest Ray-Ban Meta display, and I'm not talking about Nuance, which certainly have some particular features. For a range where it's possible that someone hasn't yet reached the point of needing a hearing aid, this year, one of my students actually wrote a thesis comparing Nuance and hearing aids. The results are staggering. I didn't expect such a striking difference, but they really are staggering. However, I realized that for a certain segment, I wonder if you don't go for a hearing aid at a certain price point, but instead you temporarily solve the issue with that. But if I think about the latest Ray-Ban displays, which subtitle the person you're talking to, the person you're looking at, just try to think about all the cases of neuropathy. Auditory neuropathy, poor discrimination, those situations where we fit a hearing aid. In many cases, we see improvement, but we still have many limitations because there are difficulties. At the core, there's poor discrimination, and with hearing aids, that's as far as we can go. Guys, if I could provide this kind of support to one of my patients, where, in addition to auditory support, I can also give them visual support, it would make a huge difference.
It's an evolution. You're talking about an even more significant evolution in the hearing aid sector. Huh?
Yep.
I'm convinced that things will move in that direction, for sure. But this awareness today, maybe not all of your colleagues have it. No, because
it's being demonized. Those aren't hearing aids. I mean, that accessory is not a hearing aid.
And so I don't take it into consideration, but that's crazy.
Exactly. I mean, I've always thought that the audiologist should be the person I turn to when I need to protect my hearing, when I need support. For these situations, I can ask for hearing advice. So you can come to me and I'll recommend an app for tinnitus. I'll suggest an ANC earbud. I'll recommend hearing protection. I'll advise you a device that can help you, even if you have normal hearing in those situations. Guys, if I think about it, now magically it seems like the Roger has come out. Focus, right? In the last 3 to 4 months, I've been getting an average of 2 to 3 calls a month from colleagues telling me, but I got a prescription for a Roger transmitter and 2 receivers, but this person has normal hearing, they don't have hearing aids. Well, yes, they exist. They've existed for years, not just since yesterday, for years. Maybe some doctors are just now discovering them, just now prescribing them, but it's absolutely our job, it's our field. It's not just about fitting someone with a hearing aid because they have severe or moderate hearing loss. Because that's where we're the ones narrowing the market and our own expertise. Because I challenge anyone, how many of us actually do this regularly? When someone comes in and says, I have a hearing problem, you run the test, it's almost normal, and you realize they don't need a hearing aid. But is it possible that you can't offer them advice to help in other situations? And there's no need to be afraid of AirPods, Nuance, Ray-Ban, or any other brand. In fact, we should be the first to implement them in our profession. To say, okay, right now you don't need a hearing aid, but you do have a hearing issue. It's not about your threshold, but you have a difficulty, and you need to solve that situation. How can we solve it? Now, the technologies are available.
There is a very strong sense among professionals that this entire sector is extraordinarily stagnant and resistant to change when it comes to true innovation, at least from the specific perspective of the audiologist. Allow me to elaborate on why this is the case. Today, even though in situ measurements have been heavily promoted and strongly recommended for well over 20 years, there is still a surprisingly large portion of practicing audiologists who have not yet even begun to consider integrating them into their daily clinical practice. So how do you explain this phenomenon? I mean, it actually significantly assists in the process to achieve a goal much more accurately and effectively. It is primarily beneficial and advantageous for the professional audiologist, but why exactly is there this hesitation and persistent reluctance?
Do you remember the results I sent you from the questionnaires we did with Pietro?
Let's explain them because this is really interesting.
Together with Dr. Scimemi, who is an audiology specialist practicing with me in Venice. We conducted our very first questionnaire back in the year 2015, when they had not even come into existence yet. There still weren't any studies on the use of in vivo measurements. It was an anonymous questionnaire that we later presented at the FIA Congress, where after collecting some general data requested from colleagues, almost 800 colleagues participated. So not in...
4, a significant statistical sample.
And I emphasize, anonymous. So we don't know who gave those answers. There was a point where the questionnaire split. Do you use in vivo measurements or not? It wasn't just yes or no, but always, often, sometimes, almost never. So those who answered almost never were directed to a part of the questionnaire where they were asked why, while those who did use them, so they were asked which signal they used, how it was displayed, why they considered it important, and so on, and the majority of them, and most of them, answered that they did use them. Obviously, now I don't...
So there was a high percentage of professionals?
From memory, around 70, just a guess.
They claim to do them?
To do them regularly. We're speaking from memory here. More than 70%. Those who did not do them were between 70 and 80. Those who didn't do them said because I don't have time. The classic excuse. The classic alibi. When I started working just a few months later, the company had me take a course. We talked about stress curves and about how many times we block ourselves in front of something. And among these, there was the classic role play, where let's say your course colleagues would start asking you questions. Why don't you do this? Why don't you do that? And you, every time you gave them answers, there are no excuses, and you start thinking about it. And you think, wow, it's true. How many times do we not do something and give ourselves an answer that we clearly know isn't the real one?
But it's so functional, so...
I don't have time to take in vivo measurements. It takes you 5 minutes. I mean, really, it also meant not knowing the procedure if you tell me you don't have time. Someone answered that, let me give you an example. They considered other verification tests more important. Which ones? I don't know, maybe the electronic ear or maybe the prosthetic outcomes. I mean, I don't know, you know. And instead, who gave the positive answer? Among the various questions, there was also a trick question about how many times a certain test, which didn't actually exist, was performed. And more than 70% told us they did it regularly, so we realized that out of those 800, only about 10% actually did it regularly, if that.
The best ones. It wasn't a reliable questionnaire.
But for us, it served as a litmus test. That's why it was redone 6 years later, adding the self-assessments, and a few less people participated. If I'm not mistaken, about 500 or 600, so still a good number. And we saw that there was an increase in the use of REM and self-assessments. Obviously, it also went into more detail. Some used self-assessments, some used REM, things like that. But there was always a trick question included, and quite a few fell for it. So even there, actually, there is this thing. I can't tell if it's fear.
So I think this is relevant to the question I'm asking you, because as I go around the various hearing aid centers, meeting many people, I've realized that the audiologist generally has a strong sense of self. They are a great professional. But the perception, and I say this and take responsibility for it, on the part of the client, when you talk about hearing aids, is not that high. In fact, sometimes I hear people say, they're crooks, they ripped me off, they gave me something I don't even use. So why is there such a distorted perception? I mean, what's the truth? Are we talking about crooks or professionals?
Both. Because unfortunately, in our field, there are still quite a few crooks as well. And unfortunately, right now, we're also limited in a good way, because the professional register still doesn't have much power to be able to say, okay, you're out. There are still so many people that I don't know how they manage to work without being registered with the association. There are many who go and sell devices in pharmacies, and they're not hearing aid specialists.
There should be a bit more thorough oversight.
Absolutely, yes.
To weed out the more extreme cases a bit.
Also, because for someone who causes this kind of damage, look, I remember when I did the masters in 2008 to 2009, and one of our colleagues from central Italy who also covered the hills. And everything he told us about a case. We're not talking about some remote place. I inherited a patient who had been scammed. He had been sold 2 analog in-the-ear hearing aids for 12,000 euros, claiming they were wireless. So this guy would go there, open up the computer, pretend to make a couple of adjustments, then clean them by slightly changing the trimmer, and put them back in the patient's ear. Just think about it. If we have colleagues like this, imagine someone from outside our field. I would be scared because you wonder, whose hands am I putting myself in? So I get rid of these people. They don't even know. They don't do in vivo measurements. They don't even care. On the other hand, I think there's also the difficulty of change, which is a psychological thing for everyone. But what if I'm already working well like this? But what if I'm making money this way and my patients are happy like this? Why should I add something that requires me to spend time and effort to learn it, understand how it works, and so on and so forth?
But everything that you are currently explaining to me right now it honestly feels to me a bit as if there is something specific that protects this particular type of professional. In my humble opinion, it is partly the entire structure of the healthcare system itself, the underlying mechanism of the healthcare system, which, when you really stop to think about it, is much more focused on lead generation. So I have to ask, do you want a completely free medical device at no cost to you? Come to me, let's see if you qualify. In what way could this phenomenon be effectively contained?
Well, definitely what you mentioned earlier. More oversight? Absolutely yes. Because we laugh and joke about it. And then they came up with the ECM game, right? At the state level, you have to do the ECMs. But what are they for? I mean, so many times people just take online courses to get credits. That's it. It ends there. I can assure you that I know some of my colleagues who, from time to time, actually, they keep surprising me, they have outstanding skills. I can guarantee an extremely high level. And every year they enroll in courses, after courses, master's programs. Sometimes they even call me to teach at some masters. And well, it's the same people. By now, you know more than we do. The ones here teaching, but they have an incredible hunger for knowledge. They truly invest everything, go everywhere, and they really want to. Sometimes I compare notes with some of them, and I can guarantee you that from theses, from studies, from projects, things have come out that I never would have imagined. So there is this hunger for growth and everything else. And then on the other hand, there are the others, those who have zero motivation. So maybe starting to do some checks in that area, rewarding in some way, creating centers of excellence. Again, regardless, independent or that doesn't interest me. Valuing those we have in this regard, but also starting to cut the legs out from under people.
Let me throw out a provocative idea. In your opinion, if the public sector were separated from the private sector, meaning we send people who can't afford it to hospitals through the public health service, while the private sector is managed in a completely different way. And I'll use the example of dentists. Today, the state gives you the option to go to the dental hospital. However, under certain conditions, the sector is almost entirely private. Wouldn't there be a qualitative growth in the private sector today?
Look, it would be enough for you not to make a discussion about private and public, but about product and performance. That is, you took the product from the famous Tragatino and you paid for the product you didn't steal from me. 12,000 euros. But I understand that if it's a little fairy, you can't regulate it. I go to another center, like with the dentist. I might have, let's say, gotten a cleaning or braces from one, then I realize it's not there. So I switch, I change dentist. Let's say, for example, I got dentures from one, but then I go to another and I'll pay the other one. It would be enough to start separating things, and this in a subtle way. The ASL also takes this into account, because even the ASL, in the portion it provides for supplies, says, for us, a certain percentage is the product, a certain percentage is the application. And that's what came out with the antitrust. That is, what emerged from the antitrust is that there is little clarity in our market, because in reality, the prices that are set are a bundle of product and services. So let's start separating them, and you'll weed out the hearing aid specialists who aren't really specialists, because they'll just sell you a device and then never see the patients again. Whereas those who do their job well, they might not even sell a device, but only do adjustments and fittings.
Nowadays, we're getting customers used to looking for a free solution. I mean, I see a lot of ads that really just seem like lead generators. If you have these characteristics, the device is free. No, if you have a hearing problem, come to us and we'll solve it for you. So do you think this is creating a distorted perception for the end user?
At least I don't perceive it that way. On the contrary, I have a lot of people who come to me and say, yes, but I'm entitled to that. I don't want the one from the ASL. I have friends who have it, but I prefer something else. And we're not talking about aesthetics. We're talking about quality. So in that sense, I see there's more of a search for information. Sometimes someone comes to me who already knows the names and models of all the devices. I've seen that this device has these features. I've seen that the other one has those features. By now,
With the internet and everything else, why did I even ask you? Because when I was talking with one of your colleagues, specifically in another part of Italy, it came up that the perception was I have to pay. No, if I have the features.
here fortunately no. In my opinion, what's a bit more of an issue, always our fault, is the matter of the free trial. You might build an application, run your tests, and it works fine for a week, but then they ask for a 30-day trial. Then we look like fools. We're the only ones. You try it out. A denture, you try it. An insole, you try it. A pair of glasses, you try them.
And what benefit can a 30-day trial actually give you? I mean, if I fit you with a prosthesis, you more or less understand the benefit right away, but that's just a starting point. The 30-day trial becomes completely useless.
Also because we're the first to say that a rehabilitation process is necessary. And it's not like glasses, where you put them on and take them off and immediately see the difference. Then, of course, in the moment you can tell if it works or not. But the tests, the adaptation, then we always come back to the same point. Have you been deprived for 40 years or just 2 days? Are you already a user or not? So I can understand that. But let's get back to the application process. So I repeat, I only work with trials because my company requires it. I only work with trials. But I'm the first to be against this. Then I can understand that it's a matter of lowering barriers. I mean, you have doubts because of the high cost of the device. You wonder if you can try it out. At least you can check that you won't risk just leaving it in a drawer, because I've heard of many people who don't use it.
The law allows you to be satisfied or get your money back, right of withdrawal. So if you want, you have a month to return a device.
I'm not in marketing, so I don't really know. But from what I understand, they've noticed that even with the satisfaction or money-back guarantee, if the patient has to pay, they're still more hesitant. But here we're getting strictly into the commercial side, and that would mean reducing the device to just a commercial product. In my opinion, even the idea of a satisfaction or money-back guarantee shouldn't exist. When you go to the dentist and you have a problem, it's not like if you're not satisfied with your dentures. You just give them back and get a refund.
I have finally discovered the perfect solution, the ideal product.
The product is the means by which I rehabilitate you. So I could understand saying, look, if then through testing, we see that the product is wrong, it gets replaced because, say, it's too weak. We see that on a manual level, you're not able to handle it, which is expected. It's like saying, I make you. If the denture is wrong, if it hurts you in one spot, I remake it for you. I don't just leave you with that one period. Okay, but even when we talk about satisfaction guaranteed or trial periods, for me, those are all just ways of thinking. Old-fashioned, like the setup of a commercial class, and we're not that anymore, whether we like it or not. We're simply not that kind of group anymore. I mean, just going back to what we were discussing earlier, especially in a situation quite like this one. The other day, I was actually having a long conversation with some of my colleagues, and we were also talking about exactly what happened a few years ago. With the launch of online product sales, legally, we are the ones responsible for the fitting, us as professionals. If I go and do the fitting on a device, on a prosthetic application that I didn't choose, I am the one who takes on the legal risks for that.
Of course.
When I hear about certain situations where they tell you they regularly do fittings on other applications, or you see this method of online sales, then you choose your own center. And with $90, you get the fitting either from someone, or as is the practice in some places or companies, where you can get the device for dogs, cats, but then you can go and have it adjusted. Wherever you want. Let's pause for a moment and consider the point of view of what the audiologist risks when doing a fitting on something they didn't choose themselves. If the patient were to sue, or if something were to happen, I, having worked on a prosthetic application that I didn't choose, would be at risk, and not just a little. Why should I do it? For free, because the company forces me to, or for $90 as a token fee just to bring things in. I mean, the mentality should change completely. We keep thinking in a commercial way. Obviously, there's also a commercial aspect at the base, because it's logical. You're buying a product that I'm selling you to do that, but you're not just buying a product. You're buying a product for a process you need to go through.
Of course, that's clear, not to everyone, but it's clear. I want to talk about young patients.
Yes.
Okay, so back in that insightful webinar we hosted together with Inventis, you mentioned something that really stuck with me. They're not just little adults, so could you talk to us a bit about the pediatric world, which I think is still a bit of a taboo in our field? I don't take them on, I'm afraid. I'd rather they go somewhere else. I've heard this too. And
hats off to those who say, I don't take them on, I'm afraid, because they don't cause harm. In fact, those are the colleagues I prefer. If they don't feel ready to handle pediatrics, they shouldn't handle pediatrics. On the other hand, if they feel motivated to delve deeper into pediatrics, they should take all the courses they want. There are actually not that many. Do a master's or deepen their knowledge with colleagues who work in pediatrics and then start practicing it. I started working in pediatrics apart from the master's, but that's because, as I mentioned, I've been working for 20 years. My father opened this place 50 years ago, and he worked in pediatrics, so I grew up in the pediatric field. However, before getting hands-on with pediatrics, even though I had someone next to me who had been doing it for a lifetime, I said, I'd like to start working in this field, but I need something more. So I took this 2-year path with the master's program. And I think that pediatrics is our field, our area of work that gives you the most satisfaction, because you have to watch the kids grow up and then you see how they change. For example, I have this habit of saying, oh, next I have a kid, and then another one comes in. These kids are now 22, 23, 24 years old, because I saw them when they were little.
And pooping.
Just the other day, I had one of my girls, she's 23 now, who came in to get her new appliances. Well, she's not really a little girl anymore because they grow up and...
You carry them with you for the whole life. Absolutely.
Because then you see them graduate and so on, and you see them start to say their first words. Now, you often even see them move on to implants. That's something I feel very lucky about because thank you. Then I keep following them. I also provide support for implants with cochlear. If they move on to implants, I don't lose them. For example, I have a family with 2 of my kids whose parents had a brilliant idea. When they got the first child implanted, they started some social media channels called In Search of the Lost Sound. And they provide support to all families. And I can guarantee you, so many people reach out to them. Once, while we were chatting in Cochrane, they told me, when this happened with Elia, we felt lost. At that point, we had done the first fitting at 2.5 months. Matthias, the second child, was the same. Now both of them have bilateral implants. But I can assure you that they managed to do it with such finesse and with a message of hope and positivity. And that's wonderful because normally we see them and watch them grow, but we only see them grow when they're here. So, by running these channels, I too can see things step by step. Their growth, their first words. First Elia, then Matthias.
From an emotional point of view, let's say it's priceless. From the point of view of the actual prosthetic protocol, explain to us a bit how. With you, it's clear that there's a strong focus on pediatrics. But what about the protocol? How do you start, and at what point do you make a change? What's the end goal? Tell us a bit about this.
So, earlier we were talking about guidelines. There are no pediatric guidelines for prosthetic application. It's one of those things that needed to be done, but still hasn't been. So that's the first big gap. So even when talking with colleagues, everyone relies a bit on their own experiences. When we talk about pediatrics, it's a huge mix, because when I think of pediatrics, I think of my patients who are 2 months, 2.5 months old. For some people, pediatrics starts at 4 or 5 years old, because they never see the 2.5-month-olds. So even there, it's different to apply something to a 3-year-old child. If something hurts, the older child will tell you, hey, this hurts, or you're too loud. They give you feedback. Regardless of the tests, you have communication and a conversation, which is something you don't get with a 2-month-old baby. If something's wrong, they definitely won't tell you. So that's already a big difference. A child is not a small adult. And obviously, the first fundamental step is the impressions. If you get the impressions wrong, the device whistles. You have to use heavy anti-feedback algorithms. Even worse, some people use frequency compression when it's not needed just to prevent feedback. So you end up causing incredible damage.
When the pediatric patient is exceptionally young and small, what I'm trying to say is, like you said, they can't give you any feedback.
But usually from the age of 3, they do give you feedback. Whether it's their first fitting at 3 years old or they've already had a prosthesis at 3, they do give you feedback.
You can start to reason about it.
Before that, you have to interpret things if a child starts taking off their devices and throwing them. If he does it occasionally for fun, that's fine. But if he only does it on one side, that's a warning sign. Obviously, when it comes to pediatrics, teamwork is essential. For me, the idea of working in pediatrics alone would be impossible. I can't even tell you how many times I talk with the clinics I work with.
Who are the professionals you collaborate with?
In pediatrics? Well, myself. Most of them are the clinic here in Reggio and the clinic in Venice.
No, I mean as professional roles. Who help you out?
So it also varies from clinic to clinic, usually. Most of the time, I interact with the audiologist, who is the one who coordinates things a bit. But there are different situations where, for example, the person who manages everything might be more the speech therapist. And so in that case, if I think about when Anna Barbot was in Parma, who is now retired, she managed almost everything in pediatrics. It's not that she made the decisions, but when we had to make changes after various things, she would call me or I would call her, you see. From the tests, this came out. Let's make this change. What modification do you suggest? How should we proceed? So it also depends on the clinic. The important thing is that there is an exchange of views between the audiologist, speech therapist, and audiometrist typically.
3 plus the psychologist. Helpful, perhaps later.
Phase, absolutely, yes, thank you. It's just that it's rare to have a psychologist within the clinic. So of course it happens to me less often, but it's a fundamental role. Among the countless theses I've seen, there was one years ago by one of my students. It was wonderful, where he had done it together with a psychologist he had met who was deaf, and it focused on the psychological reaction of the family with a child with hearing loss. How did they react differently depending on, is there already a case of hearing loss in the family? There are no cases of hearing loss. One of the two parents has hearing loss. Both parents have hearing loss. Or maybe you already have a sibling with hearing loss. Seeing how everything around could change, both from our side and the team's, depending on who you were dealing with.
Interesting.
Really, really beautiful. And so I'm telling you, of course, that changes a lot. For example, always with Dr. Scimemi. A couple of years ago, Dr. Scimemi created the pediatric audio prosthetic form specifically to help facilitate this work. Because so many times, let me give you a simple example. Once, years ago, the mother of one of my foreign little girls called me, so she also had some trouble speaking. She was alarmed and told me, the speech therapist said the hearing aid isn't working. I said, come in, we'll check it right away. I checked, everything was fine. Excuse me, but why do you think it's not working? Because she told me the LED isn't blinking. Just something that simple? I had explained to her, though maybe, given the language barrier, it was understandable, that the LED was only on to indicate a low battery, not for constant operation. For example, in the pediatric chart, we even included that, whether the LED works or not, and for what purpose. So sometimes something like this, how can it alarm a child's family? If we aren't able to provide all the information that might be needed, I'm not just talking about the audiometrist and the doctor, but also the speech therapist and vice versa. Simple examples like the frequency range of the device. Whether frequency compression is active or not, because say they do a tonal test and see that at 6,000 there's no response. But the compression isn't active because it's not needed. The frequency range goes up to 5,700 and then they ask me to increase it there. So even small things, little details are fundamental in communication. So pediatrics is a whole different world. For better or worse, though, it really changes a lot. It gives you emotions, it also gives you things to reflect on or difficulties, sometimes not easy ones, though. Then, as they grow up, there's the choice of color, of the ear mold, or the device itself, or things like that.
Thank you for sharing all your personal points of view with us about this fantastic profession. You've given us some really interesting insights to take home with us. I think anyone who listened to this podcast found it interesting. At least we hope so, but I really think they did. Thank you on behalf of Inventis.
Thank you, and thanks to Inventis. See you next time, thank you.
Goodbye everyone, have a great day.